Great. Good morning. How's everyone?
Morning.
So I just wanted to welcome you to our fifth annual symposium and thank you. You make this a very successful event. And also, as I look out there, I see a lot of therapists that I've worked with. And so I just want to present today to you the topic on multidisciplinary approach to airway management, improving the clinical outcomes from a multidisciplinary approach. So by show of hands, how many of you are part of a multidisciplinary airway trach team? Good. A few? Good. So we're going to focus on the team and their best practices with that. All right? Okay. So I'll go away and get that going. So let's go over the agenda. So I'm going to discuss what is a multidisciplinary airway trach team, the purpose of a multidisciplinary team, as well as the key stakeholders and team members. You go to the agenda. Yeah. Okay. The key stakeholders, team members, we're going to talk about additional team members as well as, I don't want you to assume, but to know the difference between a multidisciplinary airway trach team and a difficult airway response team. There is a difference. Of course, we're going to talk about best practices based on evidence research and your responsibility as a respiratory care practitioner. And also we'll look at what we're terminating the team and also the benefits of the team. And then I'll talk about the process from inline to decannulation as well as a conclusion. And then there's a video I'd like to share with you at the end. So next, let's talk about the couple of definitions. Okay, so a multidisciplinary team comprised from different disciplines who come together to provide comprehensive care and support for patients. The team works in unison, each member bringing their specialized skill set, expertise to develop and implement coordinated services and care plans to the individual, as well as the core function of the multidisciplinary team is to bring together a group of healthcare professionals to determine the patient's treatment plan. So let's look at the purposes. And again, the purpose of the multidisciplinary team is to bring together to have outcomes that's going to benefit the patient. The patient's always the center of what we do. This is why we're here to learn best practices. So our purposes of a multidisciplinary team is to provide clear, consistent, and that word consistent I'm going to use throughout my presentation, and it's a reason that I'm going to consistently say that, as I just did, as well as to address complex issues holistically, assist and reduce length of stay, as well as cost effective. We're going to talk about staff education with the multidisciplinary team and to help provide consistency and continuity, reducing adverse events, improving patient safety, and also to enhance patient outcome and satisfaction. Next slide, please. So let's look at some of the team members that go on the airway rounds. Of course, the physician, the pulmonologist, the ENT, we have you, and you're a very valuable part of the team. Nursing, whether it's RPN or LPN, depending on the healthcare facility, as well as the speech language pathologist. You can see I have an asterisk beside the quality assurance performance improvement analyst, key person to have on your team. Next slide. Additional team members, your surgeon. The surgeon is going to advise you of any upcoming procedures that the patient may have, so we won't prematurely decannulate. There's no need to decannulate the patient if they're going to have a procedure upcoming, so it's just easy for them to be placed on the vent. The wound care nurse, let's not wait until the patient's stage 1 and stage 2. When you begin to see inflammation of the skin, consult the wound care. That's what the team does. And again, we talked about the teams going around, sitting in meetings, having best practices. So and when you're at the bedside, this is when you want to consult a wound care nurse. Case management social worker will love you if you're able to get the patient decannulated, because what it does, it opens up options of discharge facilities, whereas if a patient is discharged with a trach, the challenges in DC, you have maybe two LTACs to discharge to. Psych services, nutritionists, pastoral care services. I'm not asking you to come out with that, but if that conversation is open, then you can offer that to the patient. But again, this is a discussion that you have with the team. Then one of your most valuable members is family support. I believe a lot of us, when we're at the bedside and we have the family there, and we come in one accord with the family and the patient see this, it reduces a lot of anxiety and stress in this life. Okay, one QR code response. So go ahead and scan that. We have the answers up there. But the question is, what do you consider, you'll see the choices once you scan, what do you consider to be the most valuable for a multidisciplinary airway team approach? So there's 5 responses that when I researched and looked up the information that identify that, yeah. Well, no, go back. It's actually, okay. Okay, so let's move forward. Go to the next slide. Let's go to plan B. Unfortunately, I'm not able to see this. Judy, just go to the next slide. So here are your options here. Enhanced problem solving, greater innovation, streamlined workflows, higher employee engagement, effective communication. The QR code is going to show you what your choices were. I mean, you all know how QR codes work as well as that. So maybe later in the presentation, I'll show you your response. But based on, the evidence, information, it's not a wrong choice. It's just that if you were leading a team, where would you start? So let's do old school real quick. Enhanced problem solving, show of hands, if you were to champion a multidisciplinary team. How about greater innovation? Streamlined workflows, higher employee engagement, effective communication. Okay, good, hands up, effective communication. So as you champion this, that's where you're going to start your team. That's the point that I'm making. And it's not that there's a wrong choice. It's just that how would you go about it? We have acute care hospitals, we have LTECs, we have SNFs that operate differently. So you have to identify what's best for your organization. Next slide, please. Okay, so let's briefly talk about a multidisciplinary airway team versus a difficult airway team. And we've been in healthcare for a while, a lot of us, a lot of faces that I see. The word assume, we have to really get rid of that because that leads to signal events. So the purpose of a multidisciplinary airway team, one, is to provide comprehensive long-term care for patients with chronic airway diseases, manages trachs, and ET tubes. The goal is to improve the overall health and management of patients with chronic airway. So the multidisciplinary team is doing their weekly rounds, going, assessing, and making sure things are moving according to the plan. Okay, whereas your difficult airways response team is to respond to and resolve an immediate, imminent, life-threatening airway emergency, as well as focus on patients with difficult airways and airways that are complicated. And their goal is to quickly, securely, and challenge airway, prevent failing situations in emergency situations. Next slide, please. Okay, again, the chronic team develops plan of care from inline speaking valves all the way to cap trial decannulation, as well as scheduled trach changes. And again, they may go and request additional services as well as rehab, MBS fees performed by speech. So difficult airway team is immediate, rapid response, codes, difficult intubation. The difficult airway team may come and assist the multidisciplinary team because you may not have, I'll give you an example. In our hospital, the therapists do not change trachs. But I know a lot of the therapists we work with have that experience. It's just our policy. Whereas when we get the difficult airway team, they'll come, they'll do the trach change and secure the airways. Example, more information on this. Next slide, please. So again, let's look at the team members. Some are going to cross over to both teams, such as the physician, nurses, yourself. But speech is not going to be on the difficult airway team, whereas the pharmacist and the transporter are not going to be on the multidisciplinary team. Of course, you can always reach out to the pharmacist if required. Next slide. Okay. I use the word assumption in our practice, in healthcare, it leads to a rapid response code or a signal bit. So guys, you said that your selection, if you start a team, was communicate. When you communicate, make sure you close the loop. Do not assume what the therapist said, what the physician said, because that leads to seminal events. And speaking from experience, speaking from, I know a lot of you I worked out there with, we have seen these events. Next slide, please. Okay, let's talk about best practices on evidence, based on evidence research. Best practices, one, will yield best results. I know we hear the word best practices a lot. So here's my example. Let's say I have a handful of apple seeds. I expect to get what? An apple tree. Let's keep it simple. So I plant the seeds, I water it, I nurture it, the tree begins to grow, and then all of a sudden I see the apples on the tree, but when I pick them, they're rotten. So I know somewhere in my process something went wrong. I thought I applied best practices, but I didn't get the results. So my point is, when you apply best practices, you will get best results. You may not get all the results that you see, but as you're moving forward, you're going to see results come in the team. For example, the skill set, your skill set, as you become more acclimated in changing traits, you're going to become better with and more efficient. Consistency, again, that's the word that I'm going to use throughout the presentation. Continuity, best practices, you're going to have protocol guidelines toward the process, decannulations, as well as a multidisciplinary team are effective throughout the patient journey, meaning when sutures are inserted to either discharge or decannulation, as well as focus on hospital length of stay and reducing adverse events. And I know a lot of us has walked in the room and seen that tray, leaning to the sides. One physician told me it's cockeyed. So, yeah, real. And team preparation, we need a commitment from this because it's not an easy team to get together. How many ideas have we had where we have the fire, we're excited about it, and then we get it going, then all of a sudden it begins to decline. The fire has burned and there's no consistency as well as that, and coordination of care. Okay, next slide. So let me read a little bit on the value of a team. Several articles say that the results of meta-analysis indicated that tracheostomy in the team were associated with reductions in total trach time and increase in speaker values. We want to get the patient their voice back. A multidisciplinary trach team decreased time to decannulation length of stay, trach-related adverse events. This approach improved the trach-related outcomes, namely, again, increase in speaker value. And also the multidisciplinary team reduces the average time to decannulation for trach patient discharges from ICU towards that. When we can get a patient out the ICU, now we're looking at cost effective. They're not getting the ICU charges in the hospital. It's not wasting resources with patients just sitting in the ICU. How many event patients sit in the ICU? And we know that they need to transfer out to a long-term facility. Okay, next slide. Okay, it's also established that a dedicated team improves the hospital outcome. And the hospital wants to see this. They want to see, why are you establishing a multidisciplinary team? What's the purpose of this team? And what are you doing? How does it improve patient outcome? And it also demonstrates a statistically significant improvement in the process and outcome measures. Next, thank you. Okay, so before I go over this slide, I want you to look right here in the right. So in our ICU at MedStar Georgetown, by the break room, we have this big glass window where staff and patients can write love notes, thank yous, and appreciation. This one patient wrote, "Thank you to the magnificent ICU staff for all your expertise." That's one of the words that I use, and kindness. We love you. When a patient leaves that type of note, that's second to none. They're letting you know that you took extremely good care of your loved one, and it's all collectively because of multidisciplinary teams, because of the therapists. This is why we're here today, to let you know that you do a valuable job, as well as that. So, with this, and working with patients and family, and build that relationship with them, just be genuine, be yourself. Now, will families always accept you? No. Let's be real about that. But the team has an essential role in humanizing care, better yet, compassionate care, as well as keep them involved. Once that trach is inserted, let them know what the plan is. And when you have setbacks, let the family know. A cohesive team provides not only technically sound, but also makes effective use of communication systems to avoid inconsistencies. So that's what I'm talking about closing the loop. So when you close the loop, at least communication is clear. They can go back and say, yes, you told me this. And our multidisciplinary team, the thing that I really respect about it is that when we go around, we go together. We go in a room together. Okay? And also, like I said, engage your patient families. And patients with trach, and one thing that I learned is that just because a patient has a trach, don't ignore them, because they're, some patients, and most of the patients that the team see, eventually they're alert oriented. So you want to engage with them. Just because they have a trach, don't ignore them. Don't look at the patient family, talk to them, because that will isolate them. Next slide, please. Okay, so a multidisciplinary airway team management, when grounding, there's something called PICS, it's post-intensive care syndrome. Can they follow instructions? Also, this is what the team is assessing when they go in the room. Is the patient physically decline, cognitively, mental health, risk of pressure injuries, we've talked about that, and consulting wound care, and also life degrade, depression. So we, as clinicians, we see these signs, okay, and we want to get to the right person. So this is why additional team members, such as psych service, we will reach out to. I'm not asking anyone to step out your scope of practice, but these are things that we visually see when we're in the room. Okay, and optimal timing is very important as far as reducing morbidity, intubation, and mitigating airway risk. Next slide, please. Okay, our role, just some of the steps that we would do. Once the trach is inserted, we're going to begin to evaluate for ventilator liberation. Work with the speech language pathologists. Once they come, they meet their vent settings. I know at our facilities, FiO2 less than 50, peak less than 8, rate less than 16. Of course, if they're on APRV, they're not going to qualify for that. But you want to be there to do the cuff deflation and also manage the vent to make sure that the patient is safe. And also ensure the trach tube is patent and intact. So these are the role of the multidisciplinary team, specifically right now with the RCP. Skill set to change the trach tube. Now, I know at MedStar, some of the hospitals are thinking about or want to move their staff into that. I know in one of our leadership meetings, I believe last month, we had that discussion. If you do go that direction, just make sure that the whole team is trained and make sure you have competencies behind that. Also, improve secretion management. Cap trail and management of tolerance. I do recommend that the respiratory care practitioner is the initial, does the initial placement of the cap trail, because we're there at the bedside. We manage airways. Don't put this on nursing with this. That way you can see if your patient is thriving, as well as perform decannulations. Again, that's per hospital policy. Our hospital, we do not do the decannulations. We're at the bedside, but a lot of us have decannulated patients. All right, so next slide, please. Okay, some other characteristics. Again, we talked about wing liberation, working towards decannulation. Our goals are cuff deflation, PMV and capping. So once speech does it, just like with speech, they're going to do the initial PMV. We can do the subsequent, because speech, what they do, they put the communication notes on the whiteboard in the ICU rooms or other rooms saying the patient may use inline speaking valve for 4 hours or whatever their instructions are. So just follow that, as well as downsizing, because we're working towards a process. Identify patients that require additional investigation. We talked about briefly about other team members, whether it's a surgeon, site, pastoral care, that they would benefit from in education. We have to consistently educate one another, as well as maintaining a safe environment. So when our team going in the patient room, we're looking at equipment, we're looking at signage, and I'll get into that about equipment with the quality person a little bit later. Next slide, please. Okay, so the outcomes that you want to see, remember I talked about the apple tree and the fruit and apples. We don't want to see a rotten apple, we want to see a nice crispy apple that we can bite in and get a little crunch from. So you want to see reduced adverse events, lower your unintended accidental decannulation. The team is going to improve communication. You're going around weekly, and you determine that based on your facility. So we have about maybe 20, we see anywhere from, it could go from 10 to 20 airways. So we round weekly, once a week, and we pick a day where our physicians or not attending, but our pulmonologists can attend, as well as the monthly meeting. That's the quality person, I'm telling you, and plan of care. The team is outcomes you're going to see, improved staff confidence. It's like any team, whether it's a sport team, a healthcare team. When you're doing well and you're seeing success, your confidence increase, and your confidence increase in the person to your left and right that you're working with, as well as discharge. So this is when we start communicating with case management and social worker, letting them know, hey, Ms. Smith is going to be decannulated on Thursday. Now their options open. And it's good for the family because now they may find a facility that's much closer. And also for the patient, reduce anxiety. That's huge. Once you can reduce the anxiety, you can get them off some of the medications and increase in scheduled decannulation. Next slide, please. Okay, remember I had that asterisk beside the quality person. So we can always say, just learning from our experience. If I had to start a new multidisciplinary airway trach team, 2 people I would reach out to. So I started this team back in when I arrived in Georgetown in 21, and it was during COVID. I reached out to speech because usually they have that same vision that we do. They're going to be on board right away. The next person I would get quality assurance performance improvement analysis. Why? Because they're going to chop out the fluff. They're going to ask, why do you want to start this team? Who's involved? What is the purpose? What is the goal? So they're going to eliminate a lot. You may in the beginning not appreciate it because they're going to ask a lot of questions and it's going to make you think correctly. So a multidisciplinary team will benefit by having a quality associate affiliate with the team, first for the purpose of the team and how it benefits the organization. Because when you get a project, now you have to present it to the organization to say yay or nay, green or red with that. As well as they're going to identify a reduction in patient length of stay, expedite a more efficient discharge, as well as process by creating more options, and also adverse events and unplanned decannulation. Next, additional information, they're going to report the increase in speech consults, whether it's inlines, PMV, our CAP trials, the scheduled decannulations. I'm going to show you an example of that, and also cost of the success of equipment. Our quality has developed a tool. So when we go in the room, sometimes when we first started, it was just a lot of trach equipment, just, like 6 size 4. Of course, you want the same size and size smaller, but it was a waste of resources. So we took that down, and the young lady, she narrowed it down to the cost, and we wasted thousands of dollars, and no organization, no business wants to see that with that, but we really tighten up on that. They're going to organize your meetings and maintain your reports, and they're going to also provide delegation or reviewing. Next slide. So I looked at several hospitals, but I like this one right here. This is a community hospital in Texas. They reported pre-multidisciplinary team and post. Pre is in the blue, red is in the post. You can see they looked at 102 patients. The ICU days were reduced in half once they started the team. The hospital days reduced about a week. They were able to start trach collar trials a day early, as well as they reduced ventilated days by 48 hours. And in the ICU, that's a significant cost to reduce ICU days, especially if they are unnecessary ICU days. But look at initiation of oral diet. They were able to cut that down start that about 2 weeks earlier, so the patient's able to begin swallowing, begin eating, and with oral diet, you progress to a regular diet, as well as decannulation almost a week earlier. So you can see some of the benefits of how effective and consistent a multidisciplinary team presents, as well as pneumonia. Patients with trachs, they have recurring pneumonias. So they cut that down pretty much in half from 22 to 12%. Okay, that's our hospital in Texas. Let's bring it home. Next slide. So let's look at Georgetown. What we did is, and with our quality person, respiratory and speech, we collected data from July of last year to May of this year. We looked at 66 patients with trachs that we reviewed at Georgetown, and 44 had new trachs placed at Georgetown. Our data excluded patients that had from outside hospital chronic trachs, ENT patients, and patients with laryngectomies, although we would go in laryngectomy rooms to make sure that they had the signage, they had the right equipment. ENT, although we work with them, they have malignancies, and their cases are just different, so they may not follow the same process as your team, but it's good to connect with them. Good. Next slide. So we also looked at our milestones. We looked at the number of trach placements, our speech consults and evaluation, our increased use in PMV, trach cavity and decannulation. Next slide. So what our copy person, when we presented this, we looked at out of the 44, 22 were ineligible for speech language consult. That's because they didn't reach the VENT criteria settings, maybe FR2 peak was higher or cognitively unstable. We also looked at the consults. We increased in that, as well as we had 13 PMV use. Not a lot of capping, but we're definitely moving forward in 4 decannulations. Next slide. One of the biggest things was discharge. We looked at the average discharge from Georgetown to subacute rehab, LTAC, SNFs, and acute rehab. When our patients were able to go to acute rehab, they stayed at the hospital maybe 29 days. That's less than a month versus going to an LTAC. Sometimes it's hard to place a patient at an LTAC. So again, now you have that patient on the bed. Where are they at? If you don't have a step down, they're in the ICU. Right? So these are the things that the multidisciplinary team will help the daily staff with. Next slide. Okay, so we say that our problem statement and goal statement, again, from July of last year to May of this year, 17% of our patients who receive trachs progress to capping, and our capping trials increase options, as I said, for discharge. Our goal is to increase that to 25%, and that's a very doable goal. And that's the significance, and that's what a quality person will bring. Okay, they're going to guide you and direct you. So if you have a team and you don't have a quality assurance person, go to that department, sit down with them, let them know what your goals are. And MedStar, I know we have a SMART blueprint. They're going to go with that. They're going to go with all the whys. Okay, so sit down, schedule that meeting. If you don't have a team, again, start with the quality person as well as speech. Next slide, please. Okay, so let's talk about the process. So I listed 10. Those of you that experience, or you may have your process, you may add or delete from this. But again, you're going to start with the consult to evaluate for inline speaker valve. So once that trach is in, that patient meet that criteria, and cognitively they're stable, get that consult. Let speech do their thing. Just make sure you're at the bedside with them. And again, we talked about patient and family education. You want to see those notes on the window. You want to see that patient, hey, I'm glad to see Rick, I'm glad to see Lucille, I'm glad to see Facile, walk in the room, as well as you want to make sure that they're stable, able to follow commands. Of course, we're going to do secretion management, that they have a strong cough. These are things that we do every day, but we don't take it lightly, because we don't want our patient, as I showed you with the hospital in Texas, to aspirate and get pneumonia. Ventilator liberation, and continue PMV trials once the patient is liberated to increase duration, to allow them to go throughout the day, as well as facilitate downsides of trach. Now again, respiratory, we're going to do the initial cap trials. After that, nursing can do the subsequent, but we want that patient to go from 24 to 48 hours. Each patient case will be different, but also you want to identify after 24 hours, let the physician know. And again, another thing I respect about our team is that everyone has a voice. And our physician, our pulmonologist listen. So when we recommend decannulation, they usually follow us. So that's that builds your confidence instead of it's in one ear, out the other. They're not going to listen. No, they listen to us. Because you're going there with having this information based on that patient at the bedside. And then evaluate for decannulation, whether the physician is going to do it or you get the order to do it. Next slide, please. Okay, well, we're terminating team. Remember I talked about consistency, lack of participation, inconsistency, the opposite. No guidance, the staff is overwhelmed, daily assignment. I get it, I've been there, I understand that. No commitment from the group. and excuses not to join the team. So let's be direct. If you're asking one of your colleagues to join the team and they're giving you a lot of excuses, move on, okay? All right, I just don't want anyone in here that's going to champion, doesn't have to be an airway to any team that you're champion to allow anyone to stop you, especially when you have that vision to move forward, okay? Staff not educated to a multidisciplinary team and benefits, maybe you have set an in-service in your department and let them know the benefits of this as well as short staff. So these are some real short staff and no commitment staff overwhelmed. This is real, and I get it. Some people cannot commit because of their personal life. So you just move on to the next. You have a great idea. Don't let it die. Next slide. Okay. Now the benefits: the camaraderie and success, the organization, because you're just placing the standards of excellence and quality care. Patient and family testimony. I showed you one, but I'm pretty sure a lot of you out there, family have congratulated you, thanked you, hugged you, appreciate you, asked for you to come back, as well as the patient can speak clearly with a PMV cap or if the cane lead. The team is well informed and educated. Patient safety, the team will follow the patient from initiation of trach, that's when sutures are inserted, all the way to either discharge or decannulation. You're going to be there every week. One thing that we did in the beginning, it was just myself and speech. The physician he would join in. Let me back up a little bit. When we had the idea, we included we started with the meeting. And the room was full, the fire was hot. Okay, but when we went on rounds, we pallet one area, the physician was there. We always get the nurse at the bedside, the therapist at the bedside. But then we see people fall off, and it came to a point, it was the speech and myself going on rounds together, or we would go on rounds, but we kept it consistent. We didn't stop no matter what. Don't stop. Next slide, please. Okay. Remember I was talking about don't assume? Trach signs and laryngectomy signs, I see them crisscross. Okay? Because we treat the patients differently. You don't want the trach sign over this, and then you begin, the trach come out or the laryngeal come out, you begin bagging them in the mouth, then everyone knows they're total neck breathers. This is where speech can come in and provide additional education for the staff. I know it's like last week, Dave's our educator. We had the speech language pathologist, and myself, we went in with a group of new nurses to go over some basic stuff that we do every day, suctioning, speaking valve, and the purpose of having the signage there. And I know also in MedStar, we're looking at a standardized difficult airway sign. Next slide, please. Okay, so in conclusion, I want you to identify if your hospital or healthcare facility would benefit from the start of a multidisciplinary team. So again, reach out to speech, reach out to a quality person. Again, multidisciplinary team will reduce the length of stay and be cost effective, as well as increasing speech language consult, leading to an increase in PMV use, cap trials, and decannulation. You're going to decrease adverse event. That's going to save lives, as well as reduce the morbidity, mortality, and decannulation, improving patient outcome, your team, camaraderie, and success. The organization benefit, and again, when you start a team, pallet one unit. If it's 3 or 4 patients, that's good. At least you get to build your standard of excellence and how you're going to go and how you're going to manage these teams. The quality person is going to, again, doesn't matter what day you round, you determine that. They're going to set your monthly meetings, your quarterly meetings. They're going to invite everyone, and then this is where we begin to change policies, we begin to grow and develop. Okay, so next. So I saw this cool video. I know it's respiratory week, so we're going to play. It's about 2 minutes. I know. I said respiratory week is next week, right? Didn't I say that? Yeah, okay. So I want to pay homage to all of us because, guys, you're very valuable. We appreciate what you do. We're here to learn, to get best practices. With everything today, take back to your hospital what you believe is valuable and how you can improve yourself and as well as your team. switching. Okay, that's technology, but again, so let's go past that. I want to, just thank everyone. Appreciate you coming out today. We're not going to keep it simple, stupid anymore. We're going to say simplicity is the ultimate sophistication, all right? I know there's a lot of intelligent people out there. Thank you for your time. Our time. Yeah. So are there any questions?
I was wondering, do you guys have a decannulation protocol, or do you just go by each patient and do something different?
No. Thank you. So actually we do, we're revising the decannulation to capping protocol. We're actually, and I'll share because we are on the med stop together. So we're actually, our medical director has presented it to MEC. I'm going to talk to nursing exec. So definitely in November, we had a brand new standardized protocol with also a new capping signage to place above the bed.
You mentioned respiratory therapists like changing the trachs.
Mm-hmm.
Yeah, most of us have experience doing that, having worked in nursing homes.
Mm-hmm.
But in this team, are the respiratory therapists, allowed to change the trach, or they have to, do it like with the team?
It's
like
perfect.
designated, specific.
No, good question. You're absolutely right as far as our experience, but it's per hospital policy. So if your hospital, again, like our hospital, our therapists don't change trachs, so we pretty much assist that patient. On our PICU side, the therapists are allowed to change trach, but not in the adult population.
Oh, okay. Thank you.
Got a question?
Yeah. So
we don't maintain competency, but that's within the scope of our practice. Technically, we're allowed to do that. Just, we have some who came from long term who are comfortable doing that, but trach care in Georgetown is under nursing. We don't want to change that, but that's within the scope of our practice.
yeah.
I got a question here.
I have a question.
It's warming up.
I don't know, do you have a suction protocol?
Wait a minute, I can't hear you.
Suction protocol. What I mean is, I went a lot of places when we suction, we use normal saline.
You use what?
Normal saline.
No saline?
Normal saline.
Okay. Saline.
Yeah. But the thing is, the literature says, if people use normal saline, you put normal saline, it can induce normal saline pneumonia.
So you're asking what, should we use normal saline?
How do you use it?
Well, no, we don't use saline. I mean, it's pretty much all antiquated practice.
Yeah, some places they do. Some places they do.
I mean, are you suggesting that
Yeah.
we have to use a normal saline?
No. Yeah, and our pediatric educator said we don't use it on the pediatric side as well.
By definition, you're using pneumonia.
Yeah.
The
Exactly,
stop is
exactly,
the tract
exactly.
sitting on the ground.
So here's my charge to all of us is that when we see a practice that doesn't benefit the patient, we need to get involved and speak up for that patient. And I bring it up in the department. One thing we have journal club discussions, it always can get better, but this is something you can discuss within your department of why you shouldn't use it. That's it. Hey guys, thank you. Enjoy the rest of your day. Appreciate it.